Hello everyone, myself Singh Nikita Rajesh from group number LA11921 is going to present topic traditional and modern information on operative access to kidneys and the ureters, nephrotomy, resection of the kidney, nephrectomy, pylorectomy, sutures of the ureter under the guidance of Professor Igaz Ajnipriani in the Department of Topographical Anatomy and Operative Surgery. So let's start. Operations on the kidney and ureters. Fierotropes and Bergman's method are frequently used to gain access to the kidney, while Prego's and Bergman's method are applied for the section of the ureter. Fierotropes approach, an incision is made posterior at the angle between the left spinae muscle and 12th rib. The incision is then carried out anteriorly and inferiorly towards the anterior superior iliac spine as far as anterior axillary line. Bergman's Israel approach. The exact length of the incision depends on the individual case, type of the operation, degree of the adiposity, the breadth and the space between the last rib and the iliac crest. The incision may be required to be above and the parallel to the iliac crest and the inguinal ligament as far as the abdominal inguinal rib. Here we can see the demonstration of the incision. Now incision by the Fierotropes method. Cut the commencing at the 12th rib at the bottom edge of the iliocostalis lumbarum muscle and carried out in the transverse direction towards the navel. Cut through the skin subcutaneous tissue. Superficial fascia muscle dissected around the layers of the skin is inserted. Peritoneum is separated from the renal fascia and is pulled down and anteriorly. Posterior piece of the renal fascia is dissected and the fat is pushed. Then make the ribble kidney and output it into the wound. Clamp capture perirenal adipose tissue together with the back piece of the fascia and tighten the wound by opening post-renal fascia. Then kidney. Nephrectomy. The indications are malignant tumor of the kidney, pylorogenic infection of the kidney, renal hypertension, renal tuberculosis, hydronephrosis, and hemorrhage of the kidneys. Procedure. The patient lies on the abdomen. Endotracheal necrosis is administered. The surgical approach is oblique lumbar incision by Fierotropes or Bergman's approach. The fatty tissue is separated from the kidney and is addition or dissected. The kidney is then taken out from the wound by removing the fat tissue from its wall. Renal vein, artery, posterior wall of the pelvis and the ureters are isolated. Also, with the aid of the discans ligature needle, two foam silk ligatures are placed under the renal vessels with a distance of 1 cm from each other. The ligature is tightened up and placed near the vertebral column, the 2-1 of the ligature thread and renal hilus. The vessels are intersected between the clamp and the renal hilus. The artery is intersected first and then followed by the vein. The clamp is placed 2 to 3 cm below the outflow of the ureter. A catgut suture is applied below the clamp. The ureter is intersected and the kidney is removed. A rubber draining tube is placed at the bed of the kidney. After carrying out hemostatic procedure, the wound is then sutured layer by layer.
Nephrectomy or kidney removal surgery is a procedure where a part or the entire kidney is surgically removed. Types of nephrectomy. Based on the extent of removal of the kidney, nephrectomy can be of two types. 1. Partial nephrectomy. That is, the part of diseased or injured kidney is surgically removed, leaving the healthy tissue intact. 2. Radical nephrectomy. That is, the entire kidney along with a section of the ureter, adrenal gland and the fatty tissue surrounding the kidney is surgically removed. Indications for nephrectomy. Nephrectomy is usually done for the following purposes: kidney cancer, diseased kidney, injury to kidney due to trauma, and kidney transplantation. When to avoid nephrectomy? During bleeding disorders, decompensated diabetes mellitus, decompensated heart failure, and anticoagulation medication. Tests performed before the surgery include urinalysis, kidney function test, complete blood count, ECG, CT scan, and MRI scan. Procedure for open nephrectomy. It is performed under general anesthesia. An incision is made in the abdomen or in the side of the abdomen. The ureter, that is the tube that carries urine from the kidney to the bladder, and the blood vessels are cut away from the kidney. Later, the kidney is removed and then the incision is closed with sutures. Laparoscopic nephrectomy is performed under general anesthesia. A laparoscope is passed through a series of small incisions in the abdominal wall. It is used to view the abdominal cavity and remove the kidney through small incisions. Advantages of laparoscopic surgery include shorter recovery time, smaller incisions, and fewer post-operative complications. Short-term complications of nephrectomy include infections, bleeding or hemorrhage, post-operative pneumonia, and rare allergic reactions to anesthesia. Long-term complications include hypertension and chronic kidney disease.
Nephrotomy. Indications are hydronephrosis, pyelonephrosis, calculi in the kidney. Methods. Nephrotomy incision is done on the kidney. There are two types of nephrotomy, which are complete, major, and partial nephrotomy. Partial nephrotomy is widely used and is of greater importance. During the hemorrhages from the wound is less, the complication and relapses of urolithiasis after the operation are also unlikely to happen. What is the procedure? An incision is made on the renal parenchyma 1 cm from the middle of the convex margin of the kidney. The wound is staged by the sutures. Nephrostomy. The operation is performed for persistent drainage of the kidney and improving its function. Indications are renal failure, pyelonephritis, and severe course of calculous pyelonephrosis. Procedure. An incision is made on the renal pelvis. From the incision, a finger is inserted to the calyx. Later, a small incision is made on the cortex. A probe is introduced to make contact with the finger and guided through the pelvic incision. The external end of the catheter is cut to form a valve and attached to a silk stitch to the probe, and then the probe is drawn out through the cortical incision. Pelvic incision is closed by exposure of the ureter. In general, it can be divided into two: exposure of the upper end of the ureter and exposure at the iliac end. At the upper end, abdominal portion of the ureter is exposed by the same incision as used in the exposure of the kidney. It is frequently necessary, especially in the south patients, to prolong the incision forward and exposure at the iliac portion by the extra peritoneal route. Patient lies on the back and the head is slightly lowered. A roller is placed below the pelvis on the infected side. Incision is made on the line of the fibers of the external oblique muscle with 5 cm radial to the anterior superior iliac spine. Branches of the deep circumflex iliac artery require ligation. The transversalis fascia is divided and the peritoneum is carefully divided from the fascia covering the iliacus and psoas muscles and psoas muscles. The ureter is elevated from the great vessels along the peritoneum. If the stone is located in the pelvic portion, the ureter should be displaced towards to be more accessible to facilitate the stitching of the wound in the ureter. With the patient placed in the Trendelenburg's position, the access may be gained through the medial hypogastric incision. A bladder is exposed and retracted, and the peritoneum is divided from the wall of the pelvis. The operation must be conducted carefully in females to avoid injury of the uterine. Suture of the ureters. The wound in the ureter is closed with the fine catgut suture. Through a wound of the ureter can be closed by suture efficiently. It is advisable to provide drainage for the external. Thank you and have a good day.